And what you get where parents come in and they're worried about children with respiratory presentations, but it's not just your typical bronchiolitis or wheezing, or indeed, pneumonias and empyemas. So I wanted to do a talk that focused more on the wider view and when to start thinking this is something that's a little bit funny. Let's see if flicking here works. Yeah, good. So basically the important slide is what I wanted to know when I was little. And what I wanted to know when I was little is what's unusual. So how do I identify problems and how do I investigate them? When has a cough gone on for too long? Parents say, oh, he's coughing every night, this is going on, blah, 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 no one's getting any sleep. As a parent myself, I totally get how that can freak people out. As a consultant respiratory pediatrician, getting nudged by my wife saying, that cough's a bit unusual, it's a different level of stress to when you're just seeing someone in clinic. And then how many infections is too many infections? And then when you're investigating things, do an immune screen. And I would just go, yes. And then I'd find the nearest kind registrar and say, what is an immune screen? And they'd say, well, a little SHO. And I'd get probably 5 different answers from 4 different people. So I want to have a sense of what is the list in your brain of what an immune screen really means. And then how do I not annoy everybody just by referring everything? So especially now working in a centre where I've got immunologists down the corridor, how do I not annoy them too much by saying, could this be this, could be this, could be this? So what's useful information to get before you're thinking about sending people on? So the structure of this is really going to be around everybody's previous knowledge of innate and adaptive immunity. Innate immunity is not really going to come up too much here, although you do get significant problems with it, obviously, in respiratory medicine. If your cilia don't work and you have primary ciliary dyskinesia, then you're going to find yourself in a respiratory talk at some point. Also, you will see children with MBL deficiency at some point coming in with the current coughs and colds. Cystic fibrosis is primarily a disorder of your respiratory barrier because it's an epithelial disorder. But I'm going to talk more about adaptive immunity today. So we'll do a little bit of reviewing that. So adaptive immunity, I struggled hugely with immunology at medical school and didn't really have an overview of sense of what was going on. So my little song, the antigen presenting cells connected to the T cell and the T cells connected to the B cell made a bit more sense to me, having had to do anatomy before then. And what you get, and you'll know this, but I'll go through it anyway because it's the basis for the talk, is pathogens rock up and then will either talk to dendritic cells or macrophages and get chewed up and spat out onto their surface and presented on MHC class 2. It's quite difficult to go through disorders of dendritic cells and macrophages, and do not worry, I'm not going to start talking about macrophage activation syndrome and Langerhans cells, histiocytosis. But I will talk about difficulties that you get in terms of getting immune responses to work and remembering pathogens the next time they come along. So issues with activated T cells. And then when your T cell is activated by an antigen presenting cell, it does a couple of things. It either talks to a B cell and gets it to make antibody. It talks to phagocytic lymphocytes. So neutrophils and macrophages come along and neutralize nasty nifs. Or T cells themselves, including NK cells, can do direct cell-mediated apoptosis, walk up to an infected cell and tell it to destroy itself before it starts annoying its neighbors too much. So the outline of this talk is based around what's going on in terms of adaptive immunity with directed responses really coordinated by T cells after meeting an APC. So if your B cells aren't working, you're not making any antibody, we can talk about that. If your phagocytic lymphocytes don't work, then you're going to get respiratory problems because then you're not going to be clearing infections. And if your direct cell-mediated apoptosis isn't working, or combinations of T cells and NK cells and B cells, then we will get immune problems. And respiratory pediatricians will end up seeing this stuff and should be able to pick it up. But going back to that first question, that difficult situation in A&E, you're the F2, you're the ST1, you're sent to A&E to see a child who's been in a few times, and the nurses say to you, they keep coming back. So when has a cough gone on too long? Now, it's quite useful to have a dive into a decent review in a good journal. And there's a talk later on in the week by Prof. Bush. He's a useful repository to put his name into PubMed and try and find out what's going on. And he's written us practice review in the BMJ. It's from 2018, so it's not too long ago, where I was trying to find what's the consensus. Who says a cough was too long is this amount of time? So helpfully in the introduction, it says there is no consensus on how many episodes of lower respiratory tract infections are too many. But then thankfully the article does go on to tell you what the consensus they reckon should be. And then I guess the point is then to put that up there and see who stands up and shouts and says that it's wrong. So it's okay, it's normal. You can be reassuring for parents in healthy children if they've got a common cold that's lasting up to 15 days, or they've got a cough, possibly following on from a cold that lasts up to 25 days. That's a long time. That's a lot of waking up in the night, hearing your child coughing and thinking, is this a problem? but a cough lasting up to 25 days is okay. And if you're getting recurrent acute coughs with a week symptom-free in between, that's probably just recurrent viral colds. I learned that as an ST1 at the Whittington when Bob Claver, who a couple of you will have heard of, said to me, my kids get a cold and it's gone for a few days, and then they get the next one, and they've got runny noses from September through to March. It's like, yeah, of course, Bob. Yeah, sure, Bob. Yeah, definitely. And then I now see it all the time with my own children. So it turns out he's right. And when you need to start thinking more or talking to people or putting needles into kids is if you're seeing 3 or more per 12 months of bronchiolitis or bronchitis or pneumonia, or a daily wet sounding cough for 4 weeks or more. Is that what that says on that slide? Because my go-to meeting control center is getting in the way. I think it does say that. Anyway, 4 weeks or more of a daily sounding wet cough. Now, this is in healthy kids. This is written by eminent people. It's in a good journal, but the ultimate test of that is to run it by my sister. She's a GP. She's got 3 children, and she thinks that this is sensible. So it passes both the anecdotorama test as well as getting published in a decent review. So what are the red flags? Now, red flags, if you're an A&E person, is I must do something straight away that leads to diagnosis. That's not what I mean here. A red flag is where you can justify doing investigations. It doesn't necessarily mean if the red flag's there, you're going to come up with an abnormality. And a lot of this is working out lots of relevant negatives that you can rule out for parents to say, this is not the problem, this is not the problem. But if you've got a recurrent or prolonged history, as we've just said in the last slide, kids with finger clubbing, and it does get missed, look at the fingers. It doesn't take you 2 seconds when they're walking in. Kids with finger clubbing, obviously that's a red flag. Secretions is unusual. Children under sort of 6, 7 years old should not be able to expect a rate. So if a child is 2 or 3 and has got a cough that's bad enough that they're coughing stuff up, that is unusual and should prompt you to think, is there something more serious going on here and should you do stuff? Crackles is unusual if they're prolonged. I'm not talking about during acute bronchiolitis. I'm talking about if you've got a child who's been back a couple of times and you're hearing crackles, that's a bit strange. And if you're sending cough swabs in these kids and you get funny pathogens back, you need to think seriously about doing further tests. So you should not, I mean, you can do, but you shouldn't be growing things like Staphylococcus aureus or Pseudomonas aeruginosa from the lower airway of children who are otherwise felt to be healthy. That's unusual. And I can think of a few cases in my time where we've seen children who have recurrent coughs, you do a cough swab, you grow Pseudomonas aeruginosa, and you put them through a battery of investigations. You don't find anything, you say, well, that was unusual, but you've got to do those tests if you see funny bugs like that. I'm being too verbose here, I'm taking too long on my early slides. Abnormal chest x-rays or recurrent chest x-ray changes, obviously that's odd. So then what's your differential? Because I think that if you're asking questions in clinic and asking questions in A&E, you've got to be thinking in your brain, what's the yes, no answer, or the substance of what you get back from the parent suggests to you what's going on. And you're seeing kids who've got coughs, recurrent coughs, coughs that won't go away. The list in your brain you've got to tease in and out is this persistent bacterial bronchitis? I'll talk about that more in a second. Is it whooping cough? Is it TB? Is there a foreign body that's been missed? Is it asthma? Could it be bronchiectasis? Is there other stuff going on that feels a bit more outside of the lung, like reflux or reflux aspiration? This is congenital heart disease. And then for those of you at the back, you can't see so closely. I'll put some rare immune deficiency very low on this slide because it's super rare, but have it in the back of your brain, and we'll talk through getting it to the front of your brain in a minute. So I'm going to give you a story of a child who I met who was referred to me by a very good DGH pediatrician who wasn't really feeling comfortable about whether this was asthma or not. 3-year-old, born in the UK. Why have I put that on the slide? Because if you're born in the UK, you should have had heel prick testing for cystic fibrosis. You can still have CF despite having normal newborn screening. It's rare, but you can have it. So it doesn't mean you don't do a sweat test, but it's worth knowing where they're born. And the story we got from the parents was that this child had been in and out of hospital since 7 months of age. Colds just get straight onto the chest. 7 months is a funny age because that's around the time that you wean from your placental immunity. I can't remember if that was relevant here. I'll get onto that. 1 or 2 of the parents smoked. They were on Clenil, they were on salbutamol, and the paediatrician had already started them on prophylactic azithromycin. So these are the chest x-rays. The one on the right of my screen is the one that happened acutely when they came into resus in the DGH and was sent up to us. And there's all this mucky stuff around the right heart border. And this is the x-ray when the child was well in our outpatients. It looked kind of similar, and that's about 4 or 5 months after the initial presentations to the DGH. So there's persistent chest x-ray changes, and there's a funny story of every cold getting onto the chest, so this child is worth investigating. What's my differential? Could this be persistent bacterial bronchitis? Now, persistent bacterial bronchitis, for those of you who haven't heard of it, is a term that's sort of come in and out of vogue, but is in vogue certainly probably since the mid or early noughties, where children who may well have underlying inflammation in their lungs, either due to asthma, allergy, or to previous infection, just get gram-positive bacteria stuck in there, and they have a wet, wheezy cough for weeks and weeks and weeks on end. So that's the typical history. Could it be pertussis? Could it be TB, foreign body, asthma, bronchitis, reflux? So the tests here are the sort of things that you do, and the best test is the history. So was the history consistent with PBB, persistent bacterial bronchitis? Could it be pertussis? It didn't really sound like whooping cough, to be honest, but you'll do the serology if you're going to do some bloods. TB, this is a child who's got persistent right-sided X-ray changes in a South London hospital, and they tend to get themselves a Mantu or an IGRA or both. Foreign body didn't sound like that was going on. 3 years old is a bit old, but you never know, especially in children who don't have normal neurology. Asthma, it's a punchy call if you've got an abnormal chest X-ray like that, but there could be asthma underlying the problems. Bronchitis, if you think there's enough of a story for that, you need a CT scan to rule it in or out. And then could there be reflux aspiration? And then again, for those of you at the back, some rare immune deficiencies or ILDs, interstitial lung disease, could that be going on? So this child, because there was a few various overlapping things in the history that could be reflux, could they be aspiration? We felt it was, and they'd had a couple of courses of antibiotics and not got better, and they were already on prophylactic azithromycin. We felt it was just to do a bronchoscopy in this case, because then we can do the pH or an impedance study at the same time and put it in while the child's under GA. So they had thin yellow secretions bilaterally. So when you put the bronchoscope in, you see kind of thin, kind of yellowy, mucky gunk on both sides. Nothing too thick or frightening, but stuff everywhere. That's unusual. With a slightly red lining to the lungs, as far as I can remember. Neutrophilia on the lavage. You're not supposed to have more than, I think, 20% neutrophils in your differential white cell count. And we grew Haemophilus from the culture. The sweat test is normal, so was the pH, so was the video fluoroscopy, the swallow, and the immune screen was all normal. And the diagnosis here was persistent bacterial bronchitis. There is an excellent American Thoracic Society leaflet on PPB, which I recommend you download. Just put children PPB into Google and it comes up. And it gives you all the information you need, and then you can email it to parents, including the high recurrence rate after 1 month of augmentin. This child got much better at the next outpatient review. The chest X-ray was normal, and we stopped the azithromycin and she was fine, and we ended up discharging her from the clinic about 6 months later. Lovely, a win. The second case is a patient who was a 6-month-old boy who was labelled as recurrent bronchiolitis, which I think he'd got from about the age of 2 months, and we weren't sure or clear if he totally cleared his bronchiolitis at all, and then it had come back, or whether it sort of waxed and waned. But in the end, he ended up being an inpatient transfer from a DGH because he just couldn't wean oxygen at all. His chest X-ray looked a bit grey, and the referral note said, look, could this be interstitial lung disease? So there's something funny going on here. He also had failure to thrive, which makes you think about interstitial lung disease, and hence it's worth knowing that his echo was normal. This is the X-ray. Actually, it's not. It's one that I took from a well-known website, and it's indicative of what the X-ray looked like. And basically, it's just a bit too grey all over. And you could possibly argue that the diaphragms are a little bit flat, which suggests that the child's a bit hyperinflated. So it feels like we've got a grey X-ray and possibly an airway problem. This is the CT. The thing to note about this is that if you've got interstitial lung disease, you tend to, not always, but you tend to have a diffuse grainer. So it's kind of the same two grayness all over, which is this one is a bit more patchy. And peering in closely, you get the sense that these white patches are around airways, and there's less of it at the edges of the septa. So the septa aren't thickened. So he suggests there's an airway problem, a patchy bits all over. So it doesn't feel like ILD. And at the age of 6 months, you've got people thinking, what could the differential be in this case? Doesn't feel like PPB, whooping cough, TB, foreign bodies, etc., etc. So could it be some rare immune deficiency? Because it's not fulfilling all these nice criteria for stuff that comes above. So it's time for some immune deficiency blood tests. Remember the basics and the adaptive. So this is the pathology. So this is the structure for the investigations you do. And this is where the immune screen comes in, because these are the bits you're testing with each test. So if you want to know whether the barriers work, you get a sweat test to see if it's cystic fibrosis. If you want to know how the cilia are working, you can do nasal nitric oxide, difficult at that age, and you may or may not need brushings depending on what the other tests show. You can do an MBL level, mannose binding lectin, relatively easy, and you can debate whether or not you need to do complement levels. That's the innate stuff. For adaptive immunity, you want to know, are there enough white blood cells? Okay, so you do a full blood count. Are there enough that are going to do the work of the CD4 cell? You should have an HIV test. I've given this talk previously and left that off, not massively told off, because not everybody is watching this from the UK. But most of you will know that most of our children have got a known HIV status for the parent, for the mother. You can talk about doing lymphocyte subsets, yes or no. That's easier in some places than others. And then what you really want to know, if the white blood cells are there, do the T cells work and do the B cells work? T cells tell B cells to make antibodies. So if you've been vaccinated, protein vaccine is tetanus and carbohydrate vaccines is the pneumococcus. That's why you do tetanus and pneumococcus. If the T cells work and they're able to tell B cells to make antibody, then you'll have vaccine antibodies. Do the B cells work? Well, do they get antibodies made in the first place? You can do immunoglobulin levels. And then do the phagocytes work? Do they phagocytose? In which case you can do an NBT, neutrophil burst test. Somebody's going to have to send their own blood at the same time for the normal control in the laboratory. Worth knowing. Okay, so this child had a very abnormal full blood count with a lymphocyte count of less than 0.1. And the PCR and the NPA was positive for pneumocystis. So this child actually eventually turned out to have ADA SCID, severe combined immune disorder. How much time have I got left? 13 minutes to go through respiratory presentations of immune deficiencies. Okay, so listen, the reason that we need to know this as respiratory pediatricians is because the lungs are in the front line. So lungs and guts talk to the world. Those are the epithelial surfaces. And okay, sinuses and ears and stuff, but let's argue they're part of the respiratory tract. If you hear buzzing, it's not my insect connection, it's a fly. I'm gonna let you out the window. Go on, buddy, see you. Respiratory teams might end up picking up things like SCID, common variable. Everyone's beginning to sweat and get nightmares now, remembering the first and second year of medical school, hyper IgE and chronic granulomatous disease. I'll cover a couple of these in the time we have left. SCID is an umbrella term for a group of inherited disorders that results in the lymphocytes not working. So T cells, B cells, and NK cells. And you get it around 3 to 6 months of age. Well, you're born with it, but it presents around 3 to 6 months of age as the maternal antibody wanes. So it'll be sooner if you're an ex-prem and you didn't get a nice third trimester of antibody. There might be a family history. I have been caught out by saying to a family, I think this might be going on. And they said, oh, yes, his cousin had that. And they spent a long time ago. Oh, could you think it could be that, doctor? It was a bit embarrassing, but we only picked that up later on. Always take a history so you don't look like an idiot, because I've fallen for that a number of times. Symptoms and signs: you get a persistent cough, you can get failure to thrive, persistent diarrhea, because it's not just the lungs that will harbour infections, and cryptosporidium is an unusual thing to find in small kids and should get you thinking about could there be a problem in the immune system. You get a limited response to the antibiotics because it'll help a bit, but then the underlying problem hasn't been changed. So as soon as antibiotics stop, you tend to get big problems coming back. Failure to clear colds, and also funny things like rashes on the skin. So if you get all those constellation of signs now, and you see that in a kid next week in your hospital, you can look super smart and say, could this be SCID? No talk including SCID is complete without a picture of this boy, David Vetter, who was the boy in the bubble. Look up Simon and Garfunkel if you're interested into that. And just call immunology early if you're worried, because they will tell you a series of things to do and you don't have to do too many tests at one time. No live vaccines. And newborn screening for SCID was due to pilot this year because you can pick up some of the genetic ones on the heel prick tests, but I'm not sure if COVID delayed that. Right, common variable. How long have I got? 10 minutes. Common variable is an interesting one because you'll always get people saying do the immunoglobulins, but what does it mean and what are you looking for? So it's a group of disorders characterized by decreased production of immunoglobulin. So you need to be sure that it's not that the immunoglobulin is getting used up and it's not that it's getting lost somewhere. It's predominantly that it's that they're not making it. Usually IgG. So vaccine responses won't be there, decreased or absent, okay? And you try and do a pneumococcal booster and you look for your various serotypes when you're not getting a response, But it's only diagnosed once somebody has ruled out all the other reasons for hypogammaglobulinemia. So as respiratory pediatricians or general pediatricians seeing respiratory presentations, if the IgG levels are very low or lots of Igs are low, then you think about it and then you send it on to the immunologist for more kind of expanded testing. And it's not that uncommon, 1 in 50,000. We do see rarer things. It's not that uncommon, so yeah, it's worth certainly thinking about. Tends to present in primary school age, but it might be late teenager, indeed early adulthood. And these children get recurrent bacterial infections because they can't opsonize bacteria, so they're usually gram-positive things that aren't getting hit by the IgG, labeled and then destroyed by macrophages and neutrophils. So they tend to get recurrent otitis media, sinusitis, endobronchial infection. And of course, these are the sort of things that we diagnose quite a lot in children. Sinusitis less so, it's more in teenagers. but you'll say you've got a cold. And otitis media, it's, it's a sore ear. Kids get sore ears all the time. And if you don't have someone who's getting a good overview of that and seeing the same GP every time, I realise people are getting 3 or 4 otitis media in 6 months. That's unusual. Or recurrent endobronchial infection, and you shouldn't be getting lots and lots of courses of antibiotics, as we said earlier on. They get streps, they get Haemophilus. Very active people on the internet, it appears. I've got this nice story here about basically, apparently, these children are just very upset for a long time. They're very grumpy, and it takes about, on average, I haven't got the interquartile range here, but on average 2.5 years to pick up the diagnosis of common variable once people have worked their way through family doctors, pediatricians, immunologists. I think that's the data from America. But you can end up with chronic bronchitis and bronchiectasis. So you want to pick this up early and be able to prevent that kicking off. There's an increased risk of autoimmunity as well. And treatment is aggressive organism-specific antibiotics and IVIG to get the levels up to normal. And many of you will have come across kids with common variable who go into day case in the hospitals you work in and having IVIG given to them either through a portacath or through recurrent difficult cannulas, as I get flashbacks to my time at Chelsea and Westminster doing that. Hyper IgE, Job syndrome. Listen, this is one of the benefits of searching things on YouTube, because you get the content and then you get the search hits and then you get the content straight away and get some incredible videos. Job was struck down by Satan with recurrent skin boils, and these children get respiratory infections and they get recurrent eczema, serum eosinophilia, serum eosinophilia, and really high serum IgE. Although 1/5 of the children don't have a raised IgE despite having hyper IgE syndrome, just to make our lives easier. The majority of de novo autosomal dominantly inherited STAT3 mutations, and that affects the auto-regulation through your Th17 and Treg signaling. So it just messes that up and they end up overproducing that IgE in recompense. That's what the theory is, but now it's completely clear, according to my reading earlier this afternoon before I went to the beach. But you get some stunning pictures on CT scans. So these kids get recurrent rashes, they've got unusual teeth, recurrent boils, but this is what the Staphylococcus does to the linings of their lungs. So this child has had a CT chest, they're lying on their back, feet coming towards us, head out the back of the computer. This is the left lung, looks okay. That's right lung, that's, yeah, okay, that's again, this is an enormous hole, essentially a nematocele in the right lung. And then those get secondarily infected with things like Aspergillus and Pseudomonas, which obviously is going to cause you more trouble. Then they don't necessarily present with fevers because they can't do normal cytokine signaling. So you've got a low threshold for getting X-rays and treatment dose antibiotics in these children. Now, you're not going to be running their management. If respiratory pediatricians pick up a hyper IgE, they will work with the immunologists in order to manage their care. But it's really, really worth knowing about these conditions so that you can spot them early. And they're not all STAT3, so don't send off a genetics test, have it come back negative and then think, well, that's not it and carry on. You need to talk to the people who know more about it than I do in terms of picking up children like this. Finally, chronic granulomatous disease. Well, granulomas, yes, I remember hearing about kids eating granulomas and granulomas in pathology lectures. I'm not really been sure what people are on about. But this is an interesting cause of them. So you get a disordered neutrophil and monocyte macrophage function. Essentially, they can't make hydrogen peroxide. So the NADPH subunit doesn't work. This is it talking to a lysosome, and that's a bacteria here. And a great video I found on YouTube. And basically, they don't have good functioning superoxide dismutase, and they don't inject the bleach into the lysosome to kill the bacteria. Catalase positive ones that can break it down. So you get large aggregations of non-functioning macrophages and neutrophils. We've got it all clustering together around infections, which causes a granuloma. About 2/3 of them are X-linked, so it's much more common in boys. And you get granulomas in skin, in lungs, and in lymph nodes with mycobacteria as well as Aspergillus and Staph ceration and nocardia. So they need Septrin as a prophylaxis as well as azole antifungals, aggressive treatment of infections. And ultimately, if you haven't got the functioning genes, you need to find new genes from somewhere, either getting a HSCT or else getting gene therapy, which is currently in trial stage over in the States, using lentiviral vectors to get the normal genes into the bone marrow. I think the next slide has got a big title that says summary slide. Brilliant, you've got to have a summary slide. So look, what we've talked about today are some thresholds for when to investigate in terms of how long is a cough that's going on for too long, or how many coughs and colds are you allowed to get before you can start being concerned. We've talked numbers, events, time courses, and then what red flags are. Red flags being push you to try and do some investigations, but you don't necessarily always pick stuff up. We've gone through the pathophysiology of an immune screen and what it means and what it's looking for and why you do everything in a structured fashion to rule out bits of the adaptive immunity. I talked about some of the conditions that you might end up diagnosing. They are rare, but it's good to know about them, and a little bit about management of them in the respiratory clinic. And I finished with 4 minutes to go. Thank you and good night. Oh, there's a slide in case anyone asks me to do anything difficult about SCID. I'm going to come back from that one. Right, Abby.
Oh, fab. Rossa, that was great. Thank you so much. I'm just going to have a look and see if we've got any questions. But I've got a question. We're obviously respiratory people that work in tertiary hospitals, but do you think that our colleagues that work in small DGHs should send off these immune screens, or should they be referring in to a specialist clinic first?
I think in a DGH, if I get a referral from someone who's concerned about recurrent respiratory symptoms and they've done a full blood count, vaccine responses, immunoglobulin levels, and they've taken the opportunity to bleed the child to do the IgE total and the RAS for common air allergens, that's superb. Because that stuff is all available in secondary pediatrics and I think should be done. It will help you direct your referral once you get those results back. And the thing that respiratory pediatricians add that you can't do in the DGH isn't those blood tests, it's the lung function. It's the spirometry, it's the bronchoscopy response, it's the pheno. That's what we're bringing to the party. So I think that if people do a basic immune screen, if they're concerned that there could be an underlying immune problem, and then if that doesn't help them, then send them up to us. I think that's a really good idea, personally.
Fab, thank you. Does anybody else have any questions? Wait and see.
18 people want to get on with doing bath and bedtime. I can scroll through now and see who's listening. Ajay, hey man, how are you? Oh, some of my fellows are listening in. This is good times. It's going to help them with their MSFs. I didn't say that.
I think you've stunned them all into silence, Rossa. Thank you very much. That was really, really good. And it's good to have a review of something that isn't just something that we see every day. And certainly I've seen a couple of cases of SCID in the last year that have presented quite late. So it's quite good to be thinking about those as well. Great. So if there's no other questions, I'm going to finish the talk. Thank you, Rossa.
Thanks, Abby. Thanks, everyone. Cheers.
Thanks.
Bye.
Right. Bye.